Osteoarthritis has long been considered to be the progressive wear and tear of cartilage associated with aging and excess of mechanical stress. My mission today will be to try to convince you that osteoarthritis is more than a wear and tear disease, and also involve all the joint tissue, but also inflammatory response, including the innate immunity. Osteoarthritis is a disease that currently affects 350 million of people worldwide, mainly women, and its economical impact represents between 1 to 2% of the gross domestic product of industrialized countries. These figures will sharply increase in the coming decades due to the demographic trends, the increase in the life expectancy, and the number of overweight and obese subjects. What is very important also to note is that osteoarthritis is a cause of sedentarity in young adults. For many years, osteoarthritis has been considered as a wear and tear of the cartilage characterized by the progressive loss of cartilage, which can go as far as bone denudation, as you can observe here on these figures. Until 10 years ago, the chondrocyte was considered to be the main conductor of this degradation. It was demonstrated that in osteoarthritis, chondrocyte underwent a metabolic dysregulation induced by mechanical stress and or by pro-inflammatory factors. This metabolic dysregulation was mainly characterized by overproduction of catabolic factors, including metalloproteinases, reactive oxygen species, and by a decrease of the anabolic process, mainly a decrease of the synthesis of extracellular matrix components, including type 2 collagen and aggregate. This metabolic imbalance led to the loss and the release in the joint cavity of fragments of bone and cartilage, but also of product coming from the degradation of matrix components. And all these factors, these mediators, are now called the DAMs, the damage associated molecular pattern. But osteoarthritis is considered now as a serious disease by the FDA, for which there is no cure. And I would like to share with you this definition proposed by the Osteoarthritis Research Society International. And I would like just read this definition and share that with you. Osteoarthritis is a disorder involving movable joint characterized by cell stress and extracellular matrix degradation initiated by micro and macro injury that activates maladaptive repair responses, including pro-inflammatory pathways of innate immunity. The disease manifests first as a molecular derangement, and this comes from the abnormal joint tissue metabolism, followed by anatomic and or physiologic derangement, including cartilage degradation, bone remodeling, meniscus degradation, joint inflammation, and this can culminate in illness. Now, using this picture, this graph, I would like to summarize the recent advance in the knowledge of OA physiopathology. OA physiopathology starts first by a cartilage lesion induced by mechanical stress, for example, and the release of the extracellular matrix. This release of the extracellular matrix induces the activation of the chondrocyte, which may change of phenotype, and mainly undergoes a changing in catabolic phenotype. This catabolic phenotype is characterized by the release by the chondrocyte of pro-inflammatory cytokines, including IL-1 and TNF-alpha, which can activate two main signaling pathways involved in cartilage degradation, NF-kappa B and Wnt signaling pathway. By this activation, chondrocytes start secreting a lot and many metalloproteinases, including the aggrecanase, but also collagenase like MMP1 and 13, and also MMP3, which is stromelisine, which can degrade directly aggrecan. In parallel, they synthesize less aggrecan and type 2 collagen, leading to cartilage degradation and disappearance. Recently, it was demonstrated that cells and chondrocytes located in the deep area of the cartilage may synthesize a rancor, which is a factor that can stimulate osteoclast and activate bone remodeling. Bone remodeling leading to sclerosis of the subchondral bone. Recently, in my lab, we have demonstrated that osteoblasts coming from the sclerotic area of subchondral bone and comparing to the neighboring one, have a fully different phenotype. And they overproduce rancor and IL-6, and by this way contribute to bone remodeling. But also, these factors may reach the overlying chondrocytes through microcracks and through channels, and by this way activate the overlying chondrocytes and creating a loop between subchondral bone and cartilage. But they also produce some factors like VEGF, which may stimulate blood vessel outgrowth from the bone and the invasion of cartilage by blood vessels, and the arrivals of blood induce the differentiation of chondrocytes to hypertrophic chondrocytes and the mineralization of the matrix. It was also demonstrated that some fragments, complement factors, PGA2 cytokines released from the cartilage in the synovial fluid may activate through receptors which are named PRR for pattern recognition receptors, may activate cells present in the synovial membrane, and these cells in turn secrete more and more MMP cytokines, but also other factors which may directly degrade the matrix, or through PRR may stimulate the chondrocytes to overproduce catabolic factors. By this way, you have another loops between the cartilage and the synovial membrane, which contribute to explain the use of Nsaids in the treatment of osteoarthritis. But quite recently, understanding of osteoarthritis has become even more difficult with the identification of several phenotypes. At this time, we identify 6 different phenotypes: the mechanical injury-driven phenotype, the aging-driven, the cartilage-driven, the metabolic syndromes-driven metabolite, the subchondral bone, and finally, the synovial-driven phenotype. These phenotypes can be defined and explained by a specific molecular pathway named the endotype that explain the observable properties of the phenotype. Until now, 9 endotypes have been identified and associated to molecular endotypes, which are characterized by circulating biomarkers that we can measure directly in the blood or in the urines. Today, our attention will be focused on the synovitis-driven phenotype, which is associated to 3 endotypes: the high level of local inflammation, the high levels of systemic inflammation, and finally, the phenotype characterized by role play by macrophages and neutrophils. And these endotypes are, of course, characterized, defined by molecular endotype, including biomarkers like, for example, COL2 nitrated, or cytokines like TNF-alpha, IL-6, or also MMP, for example. I suggest now that we focus on local inflammatory reaction, taking place in the membrane synovial or in the knee in the fat pad, which is also called OFA ligament. It is commonly believed that synovitis is secondary to the degradation of cartilage associated with chondrolysis and the severity of symptoms. You can observe here that from anatomopathological point of view, synovitis is characterized by villus hyperplasia, which is characterized by an increase of lying cells layer and hyperplasia, but also by perivascular mononuclear cells infiltrate, and also in the deep zone of the synovial membrane by fibrosis. In the advanced OA stage, we can also observe lymphoid nodes and the accumulation of adipose tissue in the deep layer of the synovial membrane. Synovitis is also associated with adaptive immunity and innate immunity. Innate immunity is mainly driven by macrophages that may polarize according their environment, according the inflammatory status of the joint in M1 or M2 macrophages. Innate immunity is triggered by stimulating agents. In these stimulating agents, we can find damage-associated molecular patterns, the DAMs, including the alarmins, pathogen-associated molecular patterns, the senescence-associated molecular patterns, which are a lot of factors released by senescent cells in the joint, but also by complement factors. These stimulating agents act through receptors, and these receptors are named pattern recognition receptors, including toll-like receptors, not-like receptors, but also receptors for advanced glycation and product. And the response to the stimulation are the overproduction of matrix metalloproteinases or aggregatinase, also reactive oxygen and nitrogen species, which are all involved in the degradation of cartilage matrix, and downregulations of cartilage extracellular matrix components and chondrocyte apoptosis. It is clear that in osteoarthritis, synovitis, and cartilage degradation are closely related. Indeed, during cartilage degradation, there is a release in the synovial foot, in the joint cavity, of a lot of factors, agents capable to activate the innate immunity. You can find the DAMs. The DAMs include fibronectin fragments, hyaluron, type 2 collagen peptide, for example. The SAS, the senescence-related factors include mainly GROW, TGF-beta, VEGF, but also cytokines like IL-6, IL-8, or metalloproteinases. You have also the crystals and mainly calcium-containing crystals. The complements, including the membrane attack complex, which can directly induce senescence and cell death, and also a lot of cytokines, mainly IL-1, TNF, IL-6, but also chemokines that may attract immune cells in the synovial membrane. These factors, when they are released, can bind to PRR receptors and activate cells present in the synovial membrane, mainly type A synovicites, macrophages, and T cells, which produce, in turn, MMP, ADAMS, pro-inflammatory factors that may degrade and accelerate the chondrolysis. Well, you have well understood that macrophages play a very key role in synovitis chronicity. And they are involved first in the synovial membrane, where they can crosstalk with chondrocytes and other cells in the synovial membrane. In the knee, they are also located in the fat pad, where they can communicate with adipocyte and induce inflammation of the fat pad, but also fibrosis. And they are also identified in the subchondral bone, where they can communicate it with cartilage, but also osteoblasts to control, induce some anomalies present in the subchondral bone, including the bone marrow lesion. What is very important, this is the shift between M1 and M2 macrophages. I remind you that macrophages may be M1 or M2 according their environment, according the status of the inflammation, and according the cytokines present around them. If you have an overproduction of TNF-alpha and IL-17, macrophage which shift to M1. M1, this is the macrophages involved in the cleaning up of, for example, debris, but also, for example, bacteria present in the joints. And when they are activated, this M1 macrophage produce a lot of pro-inflammatory cytokines. This is the type 1 cytokine set, and they maintain the chronicity of the synovitis. If they shifted in M2, based on the stimulation by IL-13 or IL-4, they become then what is so-called resolving macrophage, and they produce anti-inflammatory cytokines, and they are also involved in the healing of cartilage, for example. What is very important is that recently it was demonstrated that the ratio between M1 and M2 in synovial fluid of OA patient is increasing. What this means? This means that you have more M1, less M2. And what is very important is that this ratio is correlated with the Kerr-Green and Lorenz score, with the severity of OA observed at the X-ray. Well, it is clear that when and so long that macrophages receive cleaning up signals, they stay at the M1 inflammatory status and they overproduce pro-inflammatory cytokines, which induce MMP production by chondrocytes, and by this way induce the release in the joint cavity of a lot of DAMs. DAMs activate innate immunity, and mainly macrophages, neutrophils, and also natural killer cells, which can communicate it with adaptive cells, including T killer cells and T helper cells, which, according the severity and according the message that receive, produce either more anti-inflammatory, more pro-inflammatory cytokines, and by this way control the shift between M1 and M2. If you have a higher ratio of M2, you can expect that a healing phenotype of the cells and that the disease move to the resolving stage, and by this way the decrease of inflammation. And this is exactly for which in the future some company develop drugs that target M2 polarization to expecting to resolve inflammation. Well, now we will speak more about the Infra Patellar Fat pad inflammation that occur in the knee. I remind you that the fat pad is located just behind the patellar, and this is intracapsular but extrasynovial structure that play a role in the knee and protect the knee joint from mechanical damage. They stabilize, this structure stabilize the patella and serve as a cushion between the patellar tendon and the anterior tibial plateau. Unfortunately, in osteoarthritis, this fat pad undergoes structural changes, including an increase of the volume by accumulation of fat, an increase in inflammatory cells infiltration, an increase of vascularization and fibrosis, and of course, as a consequence, a decrease of the mechanical properties. Recently, the role played by the structure in OA physiopathology was well characterized. It was demonstrated that the severity of inflammation in the IFP was associated with the severity of pain in knee osteoarthritis. Increase of MRI signaling intensity is also associated with tibiofemoral structure anomalies. And finally, IFP MRI signal intensity is associated with the occurrence of knee replacement. What this means? This means that infrapatellar fat pad is also an important target when we want to treat osteoarthritis. Well, we will now move to the systemic low-grade inflammation, which is associated with osteoarthritis, and we can observe in osteoarthritis 3 important low-grade inflammation. This is the inflammaging, which is low-grade inflammation related to aging, the meta-inflammation associated with obesity, and finally, dysbiosis, which is a dysregulation of the gut microbiome. Recently, it was demonstrated that a subset of patients have an inflammatory signature, an inflammatory systemic inflammation, which is comparable to what is observed in rheumatoid arthritis. This author, Jensen and collaborators, to demonstrate that, measure in the blood of OA patient a CRP, but also what is so-called the CRP-Hem, CRP metabolite, which is derived from MMP degradation of CRP locally in the joint. They have first observed that in OA patient, the level of CRP and CRP-Hem is increased, but for example, of course, to a lesser extent than what observed in early RA or moderate severe RA. But what was interesting is that they observed that half of the patient with knee osteoarthritis has level of CRP comparable to what is observed in rheumatoid arthritis patient. And they also observed that 1/3 of this patient had a very high level of CRP-Hem comparable to what is observed in RA patient. They have also observed that patients with moderate to very high CRP-Hem were 2.5 times more likely to develop OA in the knee with no OA at baseline. This means this CRP-Hem is an indicator of biomarkers of the occurrence of osteoarthritis. Well, it was also demonstrated that no osteoarthritis is associated with the low-grade meta-inflammation. And this concept comes from a whole study published in 2008, in which the authors demonstrate the association between BMI and the risk of systematic osteoarthritis, not only for the knee, and you can observe here that the relative risk to develop knee osteoarthritis is more elevated in patients overweight or with obesity. But what was surprising is that these authors also demonstrated that the risk to develop a symptomatic osteoarthritis of the hand, which is not a loading joint, is also increased. How can we explain that? And the explanation comes from the presence in the blood of adipocytes. And it was now well accepted that obese white adipose tissues secrete more pro-inflammatory cytokines, less anti-inflammatory cytokines, but also more adipokine than the lean white adipose tissues. And it was also demonstrated that the levels of, pro-inflammatory adipokines, including leptin, resistance, with fatin, for example, increase with the BMI and the amount of fat tissue, whereas the level of anti-inflammatory adipokine decrease with the level of fat tissue and the BMI of the patients. Therefore, the link between osteoarthritis and fat tissue may be explained by the release of pro-inflammatory adipokine in the blood of the patient. Finally, I would like to highlight the role played by dysbiosis in this systemic inflammation. It is now well accepted that a lot of risk factors associated with osteoarthritis, including metabolic syndrome, trouble or disorders of the diet, aging, but also the overuse or the chronic consumption of drugs like NSAIDs, and of course obesity, may induce a dysbiosis, an alteration of the microbiota in OA patients. What is dysbiosis? This is an increase of pathobionts, this bacteria which have pro-inflammatory properties, and a decrease of the symbionts, which include bacteria that have anti-inflammatory activity. The second point is a decrease of the heterogeneity of bacterial species, and finally, an increase of gut permeability, allowing the passage in the blood of LPS, bacteria, or peptidoglycans, which can directly affect joint tissue and contribute to synovitis, pain, or cartilage degradation. Well, now I would like to try to represent this holistic view of osteoarthritis by this planetary representation, in which the planet turns around two orbits. The first one, this is the biopsychosocial orbits, in which you have as a starting point the mechanical pain. This means that patients have fear to motion because they are, of course, they have pain when they move, leading to kinesiophobia, disability which is responsible for sedentarity, physical deconditioning, which lead to anxiety and depression, which create psychological deconditioning, which are all amplifier of the pain. This is the first orbit. Secondary, we know that metabolic syndromes is risk factors for the occurrence, but also the progression of osteoarthritis, and participate to synovitis, which contribute to systemic inflammation, which is a physiopathological pathway of cardiovascular disease. And this could explain why the mortality linked to cardiovascular disease is increased in patients with, for example, knee osteoarthritis. What this means? This means that now when we treat osteoarthritis, we not only treat symptoms, pain, but we treat also a patient with comorbidities. And we have to treat comorbidities to well treat osteoarthritis. What are the most important take-home message from my talk is first that OA is associated to local and systemic inflammation, that local and systemic inflammation are associated to OA incidence and progression, and finally, that local and systemic inflammation are therapeutic target. And how can we treat inflammation in a way, locally by cold therapy, for example, and topical NSAIDs, orally with NSAIDs, but Professor Cooper will explain how use this NSAIDs, but also by CISADOA or food supplement like curcumin, for example, but also by intraarticular treatment, including corticosteroids and PRP. And what will be next? Next, this is the arrival of biotherapy with monoclonal neutralizing both IL-1 and TNF-alpha. Also biomaterials that release NSAIDs or corticosteroids, gene therapy targeting gene like IL-1 antagonist receptors, mesenchymal stem cells that may also release factors, anti-inflammatory factors, but also, of course, for example, controlled diets or treatments or comorbidities. Before concluding, I would like to remind you that the Osteoarthritis Day is next September 17, and not this date in your agenda. And it remains to thank you for your attention.
Terrific. Thank you very much, Yves, for that wonderful overview. So in the second presentation, we're going to look at the management part of the story, the available guidelines, some of the recent data on safety, particularly as they affect paracetamol and the non-steroidal anti-inflammatories, and then move to alternative approaches, including enzymatic therapy. So you've heard that this is the commonest form of arthritis worldwide. Global prevalence of knee involvement is around 4%, 250 million people around the globe. You've also heard about the heterogeneity. You have symptoms, so that is joint pain, stiffness, and loss of function. You have structure, which is imaged by radiology or MRI, and then you have actual anatomical pathology. And it's a Venn diagram between those three, but suffice to say that the pain and stiffness, the symptoms leading to functional decline, make this the form of arthritis which contributes greatest to the global burden of disability. And hip and knee OA across medicine are the 11th highest such contributor. And the years lost to disability for OA will rise by over 60% over the period that we've just gone through, and will rise by 40% over the subsequent decade and a half, the decade, of course, of healthy aging. Now, if we look back at guidelines, these almost attest to the absence of structure-modifying osteoarthritis drugs that genuinely alter the rate at which cartilage is lost and the subchondral bony reaction responds, leading to joint failure. And most of the drugs that we have are symptomatic. And so the guidelines over the last 15 years attempt to give a pyramid of use of symptomatic therapies. So if we were to use the 2012 ACR guidelines, non-pharmacological measures, including exercise, weight loss, psychosocial interventions that you heard about from Dr. Enrotin just at the end there, self-management and self-efficacy programs, physical therapy and walking aids, a stick, perhaps patellar taping for knee osteoarthritis. These comprise the base case scenario. You then add paracetamol or acetaminophen with topical NSAIDs. You then move to oral NSAIDs, including the COX-2 inhibitors, and then surgical referral with opioids at the very top of this pyramid. In the ORSI guidelines in 2014, they classified the measures after you got core treatments with those that are in patients with OA without comorbidities, and those with comorbidities for the knee alone, and then multi-joint OA without and with comorbidities as the different classifications. But at ESCAO, we wanted to focus on a care pathway for OA that could be used by primary care and secondary care practitioners. So we have the non-pharmacological and pharmacological treatments initially, with the core set being education and joint care advice, weight reduction, and exercise regimens. We then move, if symptomatic, to paracetamol or chronic slow-acting symptomatic drugs, principally the combination of glucosamine sulfate with chondroitin sulfate. If symptoms persist, we add topical Nsaids, and then if they persist still, we move to the oral Nsaid and COX-2 component of the therapeutic regimen. If there is still symptom persistence, intra-articular hyaluronic acid and intra-articular glucocorticoids, and then only to short-term weak opioids and duloxetine before going on to surgical referral, total joint replacement, or unicompartmental or hemi-arthroplasty. And it's in these different steps that I want to focus today. I want to cover more recent data on the use of paracetamol, and I want to cover recent data on the applicability and safety of the oral non-steroidal anti-inflammatory agents. So first of all, paracetamol. We start with this meta-analysis following a systematic review in the BMJ in 2015. Undoubtedly, in this review of 13 trials using paracetamol for hip and knee OA, there is a significant and borderline clinically important impact on short-term pain and short-term disability, and an effect size that averages at 0.14. However, there was, even at this early stage, 6 years ago, concern about adverse events. There was no overall difference between paracetamol and placebo in these 13 trials in the adverse event rate, but there was an elevated risk ratio approaching 4 for hepatic adverse effects. There was then, a year later, a more thorough review of safety undertaken by the group at Leeds, and I'll summarize that for you here. For overall mortality, there was a significant 28% increase in all-cause mortality that remained after you adjusted for a variety of confounding agents, and that was observable for first prescription according to longer gaps between prescription, repeat use, and repeat use with high medication persistence and possession ratios. For cardiovascular events, there was an increased risk for all events, even from as low as 1 to 2 tablets weekly, with a risk ratio of 1.19. And when you got to more than 15 tablets weekly, it went up to 1.68. When you looked at upper GI adverse events, there was a significant excess with a relative rate of 1.36. And as important, perhaps, or more, for lifetime cumulative intake on renal adverse events, the odds ratio went up for the lower cumulative dose, 100 to 499 grams, 1.8, for 500 to 2,999 grams to 2.23. Both of these statistically significantly elevated. So these studies revealed a striking dose-response relationship between paracetamol at standard doses that we use for pain relief in OA and adverse events that are often observed with Nsaids, including increased incidence of all-cause mortality, cardiovascular, GI, and renal adverse events. There was a benefit with a small effect size, as I said, of 0.14 in most of these studies when amalgamated, but the true risk of prescription may be even higher than is currently perceived in our clinical community. And it's noteworthy that at the end of 2017, the Safety Committee, PRAC, of the European Medicines Agency endorsed the recommendation to suspend the marketing of prolonged release paracetamol products with the statement that the longer acting product advantages do not outweigh the disadvantages, particularly when overdoses are also considered. And these will remain suspended until evidence can be provided of a reversed risk-benefit balance. Now let's move to the non-selective Nsaids, which are the next tier. And of course, the main side effect we're aware of over the years is upper gastrointestinal intolerance. So in this systematic review and meta-analysis from 8 years ago in The Lancet, we have diclofenac versus placebo, ibuprofen versus placebo, and naproxen versus placebo, and you can see the progressively increasing rate ratio for upper GI intolerance, 4.22 in the case of naproxen. When we combine an NSAID with a PPI, a proton pump inhibitor, omeprazole, lansoprazole, etc., and compare that with a COX-2 inhibitor, we see that we get pretty similar alterations in upper GI toxicity. So combining with the PPI leads to approximately the same improvement in GI toxicity as a COX-2 selective inhibitor or specific inhibitor gives you. And if we look at naproxen, ibuprofen, diclofenac, and celecoxib in terms of their tolerability, celecoxib is clearly associated with a lower cumulative percentage withdrawal than naproxen and ibuprofen are. Now let's go to cardiovascular adverse events. In the same format, diclofenac, ibuprofen, and naproxen, we find that the higher cardiovascular intolerability rates are for diclofenac, 1.85, and for naproxen, 1.87. And we find, of course, that the COX-2 specific inhibitors vary according to the type. So rofecoxib is clearly associated with an elevated risk of myocardial infarction and of a composite cardiovascular MACE type outcome, whereas celecoxib actually has a non-significantly reduced, but towards reduction in direction, risk of stroke and composite cardiovascular. And probably the best RCT data from the Precision trial, 24,000 patients randomly assigned to celecoxib, naproxen, or ibuprofen, and then followed forward over 34 months, you can see that all-cause mortality, cardiovascular, GI, and renal events all favour celecoxib with a variation in the non-selective NSAID sort of hierarchy thereafter. But non-inferiority was observed for celecoxib with ibuprofen and naproxen when it came to cardiovascular safety. So paracetamol is associated with increased mortality and risk of cardiovascular, GI, and renal adverse events. More careful consideration of its use is required in OA. The non-selective NSAIDs have potential for both toxicities, while COX-2, particularly rofecoxib, gives the potential for cardiovascular. GI toxicity is modulated by celecoxib, which is less toxic than the non-selective NSAIDs. Cardiovascular seems particularly a problem with rofecoxib, and all of these drugs need to be used a little more judiciously in OA for defined periods of time, as you've heard in the first elegant presentation, perhaps when inflammation is at its peak. So now just closing out with some of the other unexpected adverse effects which emerged in a more detailed systematic review and meta-analysis that we published in Drugs and Aging a couple of years ago. This took us from 2,149 studies in the literature to our combined group of 73 reviewed within the meta-analysis. And in addition to all adverse events, GI and cardiovascular, there were CNS, dermatological, renal and hepatic, and all-cause mortality. Just a taste of that meta-analysis herewith. So for upper GI symptoms, no surprises, except that in addition to dyspepsia and ulcer, abdominal pain was also apparent. For cardiovascular adverse events, we found that hypertension, which hadn't emerged in the previous systematic reviews, was a noteworthy cardiovascular complication with a significantly elevated risk, even with the COX-2 inhibitors, as was when rofecoxib was removed, persistence, but some attenuation of that elevated risk. Heart failure was important, with a relative risk of 1.68, as were, of course, peripheral and generalized edema, and these also stayed when rofecoxib was removed. We found that, in addition, for drug-related adverse events overall, for COX-2 versus placebo, the relative risk was 1.26. The ones that I've discussed are shown in the remaining rows of this particular table. So what other options do we have? Time does not permit me to talk about glucosamine sulfate with chondroitin sulfate, but that has been carefully reviewed in our SKO working group reports and in the published literature, and suffice to say that prescription grade crystalline glucosamine and chondroitin preparations certainly appear to provide a useful adjunct in pain relief. We also have a sound database for intra-articular glucocorticoid injections for transient relief of inflammation, particularly in association with aspiration of effusions in the knee. And we have a positive benefit-risk balance in some circumstances for intra-articular hyaluronic acid derivatives, particularly those of higher molecular weight. But in closing, I want to touch on an innovation in this therapeutic armamentarium, oral enzyme therapy. The combination of bromelain, trypsin and rutoside, which are of course the first two routinely encountered enzymes, but the third actually a quercetin-like agent, which has, as you are aware of, senolytic capacity also. And these agents together have both anti-inflammatory and senolytic potential. So the efficacy, tolerability and safety of this oral enzyme combination has been compared with diclofenac in osteoarthritis. You see here the change in Lacane index over a period of weeks since baseline, attributable to the oral enzyme combination, and the magnitude of that change over the baseline to end of study periods. And you see the same responsiveness for oral diclofenac. And there's really very little to choose between these two, and of course a markedly different adverse effect profile. And that is summarized in this last slide, where the oral enzyme combination and diclofenac over 3 to 12 weeks showed comparable efficacy with clinically relevant improvements in pain and pain-related function, but that laboratory data from the blood samples taken at baseline and at the end of the study show virtually no changes in the oral enzyme combination group, whereas in the diclofenac group, there was alteration in key hepatic enzymes and in red cell parameters, suggestive of both pro-inflammatory and hepatocellular effects. And this favourable benefit-risk profile suggests that the oral enzyme combination might well be an alternative form of intervention in patients with osteoarthritis who are at high risk of non-steroidal anti-inflammatory complications or of adverse events from paracetamol use. So with that, I'd like to thank you all for your attention and to welcome questioning on this new and exciting area of clinical practice. Thank you very much indeed.
Thank you very much, Professor Henrotin and also Professor Cooper. We'll now take a look at the questions, so please, attendants, feel free to add any questions. And just as a side note, this webinar will be recorded and archived, so you can watch it even later again, or if you missed the chance, you can watch it at a later time. Thank you very much.
So I suppose one of the questions that I'm receiving, why is there no such clear correlation of BMI and increased risk of hip osteoarthritis? So that is actually something that we've studied. We've had a paper in the American Journal of Epidemiology contrasting the BMI relationship with hip, with hand, and with knee. And you're absolutely right. The relationship is strongest, so highest V, lowest third of body mass index. The risk ratio for knee might be in some of the studies 7 or 8-fold, for the hip 2 to 3-fold, and for the hand about 1.5-fold. So the hierarchy goes strongest for knee, intermediate for hip, and lowest for hand. The postulated mechanisms are as follows. First, the phenotypic variability in osteoarthritis. So knee is actually the commonest joint that goes with polyarticular and therefore with hand. So that clearly the link with adiposity is not just mechanical. The link with adiposity is more about a link with either low-level inflammation or some other metabolic consequence of adiposity that joins together knee OA and hand OA. But some part of the impact on lower limb OA of obesity is mechanical, and that's the bit that we feel is more important for the hip. And when you divide hip up into superolateral hip versus sort of concentric hip cartilage loss, you find that the adiposity goes with the concentric, which is actually the inflammation part rather than necessarily the mechanical loading part. Yves, do you have any other thoughts on the hip versus the knee for obesity?
Thank you, Sirius. This was a very complete answer. Just to explain you that I have choice to show you this study because this one was of the first demonstrating the link between BMI and hand OA. And this was a starting point to the concept of the role of adipokine. But there are other prospective studies that have demonstrated the relationship between hip and BMI. And so there are, of course, some different methodology according the studies, and the studies that I show you was based on declaration, self-report of the patient. This is probably and perhaps one of the reasons for which you don't find a correlation between BMI and hip OA. But your answer was perfect, Sirius.
Are there clinical results available that would look at not only a calorie restricted, but an anti-inflammatory diet and associated potential benefits for OA? Yves, for you?
Yes, there is a very beautiful study published by Veronese and colleagues concerning the Mediterranean diet. And they have investigated the relationship between the adherence to Mediterranean diet and knee OA evaluated by MRI. And they found that people that follow a Mediterranean diet have an increase of cartilage volume evaluated by MRI. But the condition was that they adhere at least during 14 days per month to this diet. And the reason and the link was that, of course, Mediterranean diet is rich in polyphenol, in antioxidants, and this is probably the explanation for which the Mediterranean diet is protective for the cartilage and could be preventive.
Excellent. Let's see if we have any others. PPIs and long-term use, are they unproblematic with regards to their potential influence on the microbiome? Really topical question. I would say that, to be fair, we're not really sure that there is permanent, sort of long-lasting alteration of the microbiome that leads to subsequent ill health. But certainly there have been studies that have looked at the impact that these agents, which when used in upper GI, you know, in esophagitis, sciatic hernia, even before you get to peptic ulceration, they're often used long term by people in their 60s and 70s, and there are discernible alterations in the microbiome. But the extent to which those translate into either unearthing symptoms in OA or leading to structural progression of OA, I think myself that is an open question. So what would I do in that setting? Of course, you have the enzyme mixture, you have the cisadoas, but in that setting, I must admit, I would use the COX-2 specifics rather more clearly for defined periods of, say, 6 to 12 weeks during periods of inflammation. And I'm increasingly starting to use less in the way of paracetamol. You know, I think that the old days where you'd have 1 gram QDS taken for years, I really think that's an unwise use of the agent in osteoarthritis. And again, reserving it at perhaps lower doses, 1 gram TDS as required, but for short periods of time, does seem to obviate those longer term hepatic, renal and all-cause mortality effects that are beginning to be observed. Let's see, we'll just wait for another one. So what's the supposed mode of action of oral enzymes used in osteoarthritis? So wonderful one for Prof. Henrotin.
Thank you, Sirius. Yes, there are many mechanisms of action through receptor or without acting on receptors. But one of the best investigating one is that enzyme can be trapped by macroglobulin, and they change their activities by this way, and they can capture pro-inflammatory cytokines. And by this way, they restore the balance, the good balance between anti-inflammatory and pro-inflammatory cytokines. This is one of the mechanisms of action that is now recognized. But we hope that the future studies, because we have now started important study investigating the mechanism of action of this enzyme, and we will investigate it a lot of parameters, including proteomic analysis of the blood of patient taking this compound, and by this way, I'm sure that we will bring new mechanism of action, new explanation.
Absolutely. And as I was intimating just briefly, because I didn't have time to go into it, once you get into senescence-associated secretory proteins and senolytic therapies, and you have the quercetin-like, flavonoid component within it, even though the doses may be different, it will be jolly interesting to see even potential structure as well as only symptoms. We start with symptoms. Your trial will be very exciting, I think. And I think we have an open mind here. It'd be jolly interesting to see what the future research turns up.
Thank you, Sirius.
Well, I think that just keeping a weather eye on the clock rather suggests that we've run out of time. So I'm very sorry, but I must just close out by saying thank you so much to Professor Enrotin, and of course to our sponsors today, Nestle, for a wonderful sort of overview of a novel area within osteoarthritis therapy. And just hand back over to Stephanie to make one or two closing remarks. Thank you very much.
Thank you, Sirius. This was a pleasure to present with you and to manage this webinar with you. And thank you to Dr. Rowe for to have chaired this webinar.
So thank you very much, both presenters. It was really wonderful, and I learned a lot as well. We again, a note for the attendees: we record this webinar. It will be available on the website that you've registered to, so you can watch it anytime. So with that, I wish you a wonderful day or a wonderful evening, depending on your time zone. And maybe one or two of you watches the soccer game as well. So thank you very much.